Welcome to the Deep Dive, presented by Optic Surgeon, the ophthalmology podcast.
Glad to be here.
Today we're diving into night blindness, or nyctalopia as we know it clinically. Really essential stuff for ophthalmology residents and final year MBBS students.
Absolutely. It comes up more often than you'd think.
Yeah, so our goal here is to really unpack the key info you need, get straight to the point based on the material we've reviewed.
Yeah.
Think of this as your focus guide for clinics and exams.
Right. We want to give you a solid framework.
So the plan is start with a quick clinical hook, cover the key facts, dig into causes, diagnosis, management, and finish with a nice high-yield pearl.
Sounds good. Let's do it.
Okay, let's jump right in. Imagine this scenario.
Yeah.
You got a younger patient, maybe late teens, early 20s, and they come in saying something like, well, they just don't see very well when it gets dark. Like maybe struggling walking home at dusk, or it takes ages to adjust when they walk into a dark restaurant or, movie theater.
And that right there, that's your trigger. It sounds simple, maybe like they just need glasses updated, but that specific complaint trouble when the light level drops or that delay in adapting.
That points towards nyctalopia.
Exactly. It suggests something more specific is going on with their retina, likely the rods. Needs a closer look.
Okay, so let's unpack that. Nyctalopia, at its core, what are we talking about?
Fundamentally, it's just the inability to see well in low light. Simple as that. But
Yeah.
why is the key? It points directly to a problem with the rod photoreceptor.
Right, the rods. There are specialists for dim light vision, scotopic vision. If they're not working right,
You lose that ability. You can't see well in the dark. That's the main symptom. Difficulty seeing at dusk or in dimly lit places.
but there's that other really key symptom. You mentioned the adaptation part.
Yes, delayed dark adaptation. Critically important to ask about this. It's that really slow, sluggish recovery of vision when going from bright light to dim light.
Like walking inside on a sunny day.
Precisely. For most people, it's pretty quick, seconds maybe. But for someone with nyctalopia, it can take many, many minutes, or sometimes they feel like they never fully adapt. It's a very specific sign of rod system trouble.
So besides just poor night vision and that slow adaptation, what else might clue us in? Any associated symptoms we should listen for or look for?
Yeah, definitely. You might hear about photodysphoria, that's discomfort in bright light, sort of the flip side.
Okay.
In really young kids with early onset conditions, you might sometimes see the oculodigital sign, that eye poking or pressing.
Right.
Also, look out for a paradoxical pupillary response. That's where the pupil actually dilates in light and constricts in the dark, totally backwards.
Weird. And refractive errors.
High refractive errors, yeah.
Yeah.
Especially high myopia, sometimes high hyperopia, they often go hand in hand with certain inherited types of nyctalopia.
And if it presents really early, like infancy.
Nystagmus is common then, maybe showing up around 8 to 12 weeks. And while rods are the main issue, if cones are also involved, patients might complain about photophobia sensitivity to bright light.
And peripheral vision, always important to ask.
Crucial. Conditions like retinitis pigmentosa often cause progressive loss of peripheral vision, sometimes described as tunnel vision, or maybe a ring scotoma, like a donut-shaped blind spot. And eventually, central vision can go too in those progressive ones.
So the history taking is really key. It's not just trouble seeing at night. It's digging deeper.
Exactly. How long to adjust, bright lights bother you, bumping into things. That detail is vital for figuring out what might be going on.
Which brings us neatly to the causes. Because nyctalopia itself isn't the diagnosis, it's a symptom. So what kind of things cause this rod dysfunction?
Right, it's a signpost, and the underlying causes are really varied. You've got inherited conditions, acquired problems, things affecting the retina directly, or even systemic health issues.
Let's start with the big category, inherited retinal dystrophies.
Okay, and the classic one everyone learns first is retinitis pigmentosa.
RP.
RP. It's actually a group of disorders, all progressive, where the rods degenerate first and often the cones follow later. Night blindness is usually one of the very first things people notice, sometimes years before the peripheral vision loss is obvious.
And when does RP typically show up?
Often starts in the 2nd to 5th decades, so teens to 40s, but some genetic types can start earlier.
And on exam, what are the classic signs you look for in the fundus?
The classic triad. You look for narrowed retinal arterioles, a sort of waxy-looking pallor of the optic nerve head, and those really characteristic bone spicule pigment deposits, usually out in the mid-periphery first.
Got it. And the ERG would be?
Markedly abnormal. Reduced or even undetectable rod and cone responses. You might also see that paradoxical pupil thing we mentioned.
Okay, so that's RP, the progressive one. What about conditions that are present from birth, maybe a key differential?
That would be congenital stationary night blindness, or CSNB, keywords. Congenital and stationary. It's there from birth, but crucially, it doesn't get worse over time.
So not degeneration.
No, it's more of a dysfunction. Either the rods themselves aren't working quite right, or the signal isn't getting passed properly from the rods to the next cells, the bipolar cells. It's genetic, various genes involved like NYX, CANA1F.
And what are the features of CSNB? How does it present?
Well, lifelong night blindness, obviously, often associated with nystagmus, maybe reduced visual acuity, often high myopia, and sometimes that paradoxical pupil again.
Okay. And the fundus exam.
This is the really interesting part. Often the fundus looks completely normal or maybe just subtly abnormal.
Wow, so the diagnosis relies heavily on.
The ERG, it's definitively abnormal in CSNB. You often see a specific pattern like a negative B wave, or maybe the rod response is just absent altogether. It points right to that transmission problem or rod dysfunction, even with a normal-looking retina.
Very important distinction.
Yeah.
What about really severe early onset conditions?
You have Leber congenital amaurosis Celsiae. That's a tough one. Severe inherited retinal dysfunction presents usually in infancy, leads to really profound vision loss very early.
And features there.
Nystagmus again, poor pupil reflexes, often high hyperopia, not myopia like CSNB. And the ERG, essentially flat. Absent or minimal responses, indicating really widespread retinal problems.
What if both rods and cones are affected from the start?
Then you might be looking at a cone rod dystrophy. As the name suggests, both are affected. Patients get night blindness and poor dark adaptation from the rod issues, but they often have more prominent or earlier problems with central vision, color vision, and light sensitivity because of the cone involvement, maybe more so than typical early RP.
Okay. There are also some specific conditions mentioned with very distinct fundus appearances, right? Like white spots.
Exactly, like fundus albipunctatus. That's congenital, stationary, causes Nyctalopia, and you see these characteristic little yellow-white spots scattered around the posterior pole. Dark adaptation is very delayed.
And Oguchi disease. Sounds similar.
Oguchi is actually considered a type of CSNB. It's famous for something called the Mizuo phenomenon. It's really unique. In the light, the fundus has this weird grayish or golden sheen.
Like a cat's eye.
Kind of, yeah, like a tapetum. But then if you keep the patient in the dark for a long time, like maybe an hour or more, that appearance disappears and the fundus looks normal again.
Fascinating. Okay, and then there's retinitis punctata albicans. More white dots.
Yes, similar look to fundus albipunctatus with the white spots, but here's the critical difference. Retinitis punctata albicans is progressive. Unlike the stationary albipunctatus, here the vision, visual fields, and night blindness get worse over time, and the ERG is abnormal and deteriorates.
Got it. The material also lists a few others like choroideremia, gyrate atrophy.
Yeah, those are mentioned. They definitely involve retinal changes and vision loss, but maybe the specific link to Nyctalopia as the main presenting feature wasn't quite as emphasized in the source material compared to RP or CSNB.
Fair enough. Okay, let's switch gears from genetics. What about nutritional causes?
Hugely important, especially globally. Vitamin A deficiency is the classic one. Xerophthalmia is the term for the eye signs.
And the mechanism there.
Vitamin A is absolutely essential to make rhodopsin, which is the light-sensitive pigment in the rods. No vitamin A, no rhodopsin production. Rods can't function in the dark. Simple as that.
And you see this in
Malnourished populations, typically. You might also see other signs like dry eyes, conjunctival dryness, or even Beteau spots, those foamy patches on the white part of the eye.
Okay. And zinc deficiency, how does that fit in?
Zinc is involved in how the body processes and uses vitamin A. So if you're low on zinc, you might not be able to utilize the vitamin A you do have effectively, which can lead to abnormal dark adaptation and potentially night blindness.
Interesting. What about other maybe less common causes or things that mimic Nyctalopia?
Well, something listed as quite common is just plain old pathological myopia or even just significantly undercorrected myopia.
So just being really nearsighted.
Yeah. It's not true rod dysfunction, but if your vision is blurry to begin with, it's going to be even harder to see when the light is low and contrast is poor. So people complain of poor night vision.
Makes sense. What else?
Advanced glaucoma or significant optic atrophy. If the optic nerve is badly damaged, that can certainly affect vision in all lighting conditions, including low light.
Okay.
And pharmacologic miosis, meaning really constricted pupils, maybe from certain eye drops like pilocarpine. Less light gets into the eye, so naturally it's harder to see in the dark.
Are specific medications often culprits?
Well, the material mentions some drugs can have ocular effects. Quinine, for instance, is linked more to shimmering lights, not really nyctalopia per se in the text. Phenothiazines, chloroquine, nicotinic acid are also listed as having potential eye effects. But again, the direct link specifically to causing nyctalopia wasn't strongly detailed in what we reviewed. Something to be aware of, perhaps.
And surgical side effects?
Post-pen-retinal photocoagulation, the laser treatment for things like diabetic retinopathy, is noted as potentially causing night blindness. Destroying peripheral retina can impact rod function.
Right, liver disease.
It's like cirrhosis, yeah. The idea is that the liver is crucial for vitamin A storage and metabolism. So severe liver disease could impair that, potentially leading to a deficiency in nyctalopia. But again, the material didn't elaborate much on this link.
Okay. And finally, things like albinism, aniridia, achromatopsia.
Right. These often involve generally poor vision, maybe nystagmus, paradoxical pupils. Achromatopsia is total color blindness, so that's severe cone dysfunction, but it definitely impacts overall vision and sensitivity, including in low light.
Wow, okay. That's a really broad list of possibilities. So how do you actually approach the diagnosis? How do you narrow it down?
Yeah, it seems daunting, but the workup is logical. And step one, absolutely number one, is history. We keep saying it, but it's crucial.
Asking those specific questions.
Exactly. About the low light vision, the time it takes to adapt, family history of eye problems, any systemic issues, nutrition, liver disease, medications. You often have to pull this information out. Patients might not think to mention it.
Okay, history first, then what?
Then you move to testing. Formal dark adaptation testing can directly measure how well the rods recover over time. It plots a curve, and you can see if it's abnormal, characteristic of things like CSNB or fundus albipunctatus.
And the big gun test.
The electroretinogram, the ERG. It's probably the single most powerful tool for sorting out many of these retinal causes.
How does it help differentiate them so well?
Because it measures the electrical responses of the different cells in the retina rods, cones, bipolar cells, so you get objective data. CSNB often gives that negative B wave or no rod response.
Right.
RP shows really reduced or absent rod and cone signals. LCA, the severe one, basically shows little to no response at all. It really helps pinpoint where the problem lies.
And visual field testing.
Definitely important, especially if you suspect something progressive like RP. Look for peripheral loss, that ring scotoma pattern, or just generalized constriction.
And you need a good look at the back of the eye.
Absolutely. Careful fundus examination is essential. Are there bone spicules, white spots, optic nerve pallor, arteriolar narrowing? Or is it totally normal, making you think more strongly about CSMB?
With all the genetic causes, what about genetic testing?
It's becoming much more common and useful, especially for confirming inherited disorders like the specific type of CSNB or RP. It helps confirm the diagnosis, understand the inheritance pattern, and it's vital for genetic counseling for the patient and family.
And if you suspect something systemic, like the vitamin deficiency or liver issue,
then you'd order a systemic workup. Blood tests for vitamin A, zinc levels, liver function tests, maybe autoimmune workup if you're thinking about something rare like melanoma-associated retinopathy.
Okay, so with all that, what conditions might just look like nyctalopia but aren't really the same underlying rod problem? The differential diagnosis.
Yeah, the mimics. Like we said, simple undercorrected myopia is probably the most common. Just blurry vision made worse by low light.
Makes sense. Cataracts.
Cataracts definitely make vision worse, especially with glare and in low light, but it's usually considered more of a general visual impairment from the cloudy lens, not specifically a primary rod dysfunction like the dystrophies.
Okay. Advanced glaucoma.
Yes, significant optic nerve damage can affect low light vision too.
Macular degeneration.
Typically causes more central vision loss. Isolated night blindness isn't its usual calling card, unlike the rod dystrophies.
And optic neuritis.
Much more likely to cause issues with color vision or sudden central vision loss. Night blindness would be a pretty rare way for it to present.
Okay, that helps narrow things down. So once you have identified the cause, how does that actually guide the workup and the management?
It's totally dependent on the cause. That's the whole point of the workup.
Right. So if it's vitamin A deficiency.
That's one of the treatable ones. Management is straightforward. Give vitamin A supplements, either oral or sometimes intramuscular, and crucially, address the underlying malnutrition.
Okay. What about for CSNB, since you said it's stationary?
Yeah. Right, it's not progressive, so management is supportive.
Yeah.
Focus on maximizing the vision they have. Correct their refractive error, especially if they have high myopia.
practical tips.
Counsel them on using bright lighting for tasks, maybe carrying a flashlight when out at night. If they have photophobia, sunglasses or wide-brimmed hats can help a lot. It's about adaptation strategies.
And for the progressive ones, like RP.
Again, supportive care is the mainstay currently. Things like tinted lenses might help with contrast or glare. As vision gets worse, low vision aids are essential. Vocational rehab can be really important. And genetic counseling is critical because it's inherited.
What about other dystrophies or systemic causes?
Similar approach. Supportive care, monitor for complications like people with RP can develop cataracts, so you need to watch for that. If you find a systemic cause, like zinc deficiency or confirmed liver disease impacting vitamin A, then you treat that underlying condition. And, the material mentioned possibly avoiding certain medications if they're suspected contributors, like those phenothiazines or chloroquine, though again, the direct link wasn't fully detailed for Nyctalopia specifically.
Is there a sense of urgency depending on the cause?
Yeah. Definitely. The stationary things like CSNB or fundus albipunctatus are generally lower urgency in terms of needing immediate intervention, though diagnosis is still important for counseling.
Moderate urgency.
For the treatable deficiencies, vitamin A, zinc, you want to diagnose and treat those promptly to stop any worsening and hopefully improve symptoms.
And high urgency.
For the progressive dystrophies like RP or LCA, early diagnosis means earlier genetic counseling, planning supportive care, monitoring. Also high urgency if you're ruling out something serious systemically, like a malignancy potentially causing melanoma-associated retinopathy.
Okay, so pulling this all together, if you had to give one high-yield pearl, something really crucial to remember about Nyctalopia.
I think the absolute key thing is the power of history. Really drilling down on those symptoms. Patients often won't just tell you they have trouble seeing in the dark unless you specifically ask. Any difficulty in dim light? How's your adjustment from bright to dark? Don't assume. Always ask.
It's a great point. Miss the question, miss the diagnosis. Anything else?
Yeah, another really critical concept is distinguishing between progressive conditions like RP or retinitis punctata albicans and stationary ones like CSNB or fundus albipunctatus.
Why is that distinction so vital?
Because it completely changes the prognosis, the counseling you give the patient, and the long-term management plan. And remember that pearl about CSNB, if someone has significant night blindness complaints but their fundus looks normal.
Think CSNB and get an ERG.
Exactly. That normal fundus can be misleading if you don't consider CSNB.
Fantastic insights.
Yeah.
So just to recap this deep dive on Nyctalopia,
Yeah.
it's a symptom, means the rods aren't working well, causing poor vision and low light.
Right. And the causes are incredibly diverse, from inherited dystrophies like RP and CSNB to nutritional issues like vitamin A deficiency and other acquired or systemic problems.
And getting to the bottom of it requires really good history taking, a careful exam, and specialized tests, especially ERG and dark adaptation.
And that distinction, progressive versus stationary, is absolutely key for guiding your patient.
Couldn't agree more. Well, that's a wrap for this deep dive. Stay focused, keep learning, and please subscribe.
Keep those rods and cones in mind.
This has been Optic Surgeon, the Ophthalmology Podcast.